So welcome to day 3 of the conference. This session is entitled Thyroid Cancer Management During COVID-19. We have 3 distinguished panelists with us today. I'd like to introduce Dr. Tony Beninato, who is an endocrine surgeon at Rutgers CINJ of New Jersey in New Brunswick, New Jersey. Dr. Beninato is an assistant professor of surgery at Rutgers Robert Wood Johnson Medical School. She earned her medical degree at Rutgers, New Jersey Medical School, where she was elected to the Alpha Omega Alpha Honor Society and completed her internship and residency at New York Presbyterian Weill Cornell Medical Center. Dr. Beninato research focus is on healthcare disparities and access to care in patients with endocrine malignancies, with a special interest in studying the behavior of rare subtypes of endocrine cancers. Dr. Claire Graves is an endocrine surgeon and assistant professor of surgery at the University of California, Davis in Sacramento, California. After graduating from Yale University and Mount Sinai School of Medicine, she completed her general surgery residency at New York Presbyterian Columbia University Medical Center. During her residency, she also completed a postgraduate research fellowship with the Surgical Innovation Group at the University of California in San Francisco, where she returned after residency to for an endocrine surgery fellowship. Her research interests include surgical outcomes and patient quality of life, as well as surgical innovation and device development. And lastly, we have Dr. Carrie Lubitz, who is an endocrine surgeon at Harvard Medical School in Newton, Massachusetts. Dr. Lubitz is an associate professor of surgery and section head of the Massachusetts General Hospital Endocrine Surgery Unit and a senior scientist at the Massachusetts General Hospital Institute for Technology Assessment. Her research focus is to improve the health and well-being of patients with benign and malignant endocrine-related diseases. She is the principal investigator of an NIH NCI R01 type merit award to examine the potential impact of new diagnostic technologies and personalized management strategies in patients with thyroid cancer using mathematical disease simulation modeling and an American Cancer Society Research Scholar Award to develop a patient-reported instrument to assess thyroid cancer-specific quality of life. We thank you all for being here, and I will hand it over to Dr. Lubitz.
Thank you, Roberta. I appreciate it. Well, first of all, thank you all for inviting us, the organizing committee, and Gary Bloom, who put together a really fantastic program. This is fortunately, I think my 2nd or 3rd year speaking at this meeting. I can't believe there have been 24 of them already, and also have been in the past sponsored for my research by ThyCa through the AAES and ATA. So I appreciate being here, and it's an honor to speak to a portion of our patient population. So I hope you find our talk stimulating today. A lot of things are ongoing in the management of cancer patients in general and thyroid cancer patients, and there's more to come, but I hope we can elucidate a few things that we've figured out. So I'm going to introduce things that most people already know about, but I have no conflicts of interest, no disclosures. So to date, as many of us know, 45 million cases of COVID, 224 1,000 hospitalizations, and over 733,000 deaths in the United States, with the current spike that we're finally seeing a decline from. So switching over to the impact of COVID-19 on care in general, there have been a number of large-scale surveys, one through the CDC, which showed that 41% of Americans delayed or avoided sorry, there's an alarm going off in my building, and 12% avoiding urgent or emergency care. And another large scale survey through the Harvard School of Public Health and Robert Wood Johnson Foundation and NPR, they show that 1 in 5 patients were unable to get or delayed getting medical care, and 1 in 7 had delayed or unable to get elective procedures or surgery. And 54% reported negative health consequences. So all 3 of us on this panel today are endocrine surgeons, and we remember, at least on my part of the country and Tony's, the dip in surgical procedures. You can see on the left side there, our shutdown was, I believe, March 17th, and you can see the tremendous dip in elective procedures, surgical procedures, and that 39 states issued elective procedure guidance, but this had never happened before, and it made it challenging and institution specific about which procedures were considered elective and which were not. So this is another study from the American Cancer Society. Now we're just looking at cancer patients, and they surveyed more than 1,200 patients and showed that, as you can see, even patients who had active cancer treatment going on had a delay. 25% of them had a delay or canceled in treatment. They care or treatment delay and didn't know when it would be rescheduled, up to 12 to 13%, which I am sure caused tremendous anxiety for that patient population. And obviously showing telemedicine has become really the standard over the course of this past year and a half. This was an interesting study. This is by CISNET. This is getting back to one of the things I do in my research program, is using microsimulation modeling, which is a way to simulate a population and think about potential impacts over the course of over a pandemic or a period of time. And this is just showing in comparison to the normal treatment and screening process that they estimated that there would be an increase in excess number of cancer-related deaths, at least in breast and colon and colorectal cancer. So we were given, there were a number of guiding papers that were put out, expert opinion about which patients should be considered elective surgery. And for thyroid surgery, they were all considered elective, except for those with current or impending threat to life or threatening morbidity with local invasion and aggressive biology. So a large number of patients were postponed to having their surgery. This is another paper put out in endocrine-related disease, showing, giving us some guidance in terms of whether you add this ATA risk stratification, so low, intermediate, or high risk based on the tumor characteristics, and whether or not those patients should be delayed. This is not really based on any data. However, it did provide some guidance to move forward. The American Association of Endocrine Surgeons also released a statement. So we had some guidance along that way. One paper did show, does the history of having thyroid cancer pose a risk if you did develop, or if a patient developed COVID-19 or survivor? So they showed no increased risk of developing COVID or worse outcomes. No evidence that recent history of thyroid surgery had a greater risk of infection. They said that radioactive iodine therapy in and of itself did not produce an immunosuppressive status. However, isolation or other challenges when giving radioactive iodine were posed. And the one caveat they had is that patients who had external beam radiation for their thyroid cancer, which is quite rare, small number of patients, but that those patients should be considered immunosuppressed or be careful with exposures to COVID, as we all should be. One thing I wanted to bring up, because my patients ask me this quite often, is, and this isn't necessarily thyroid cancer patients, but a lot of our population, patients who have hypothyroidism, so Hashimoto's thyroiditis, and whether or not they have an increased risk or should be considered immunosuppressed. So in this very well done study of over 30, these are all patients in New York after the shutdown, and they compared 3,700 patients that were COVID positive. Of that group, about 7% had pre-existing hypothyroidism that required them to have thyroid hormone replacement. And fortunately, hypothyroidism or Hashimoto's thyroiditis was not associated with an increased risk of hospitalization, mechanical ventilation, or death from COVID. So good news on that front. And this is just showing the survival curve, showing that they're pretty much equivalent. So one thing that came out of this, and it's called the lemonade study because trying to make lemonades out of lemons, obviously. Myself and actually both Dr. Graves and Beninato are taking part in a study that we want. This is one of those opportunities where there was a delay in treatment that was imposed upon us. And so I felt it behooved us to study these patients. So we sent out a notice through the American Association of Endocrine Surgeons that we're all members of. And there were 27 institutions that joined us. So this is a large group of patients. 4 different countries were enrolled. It was a 70-item qualitative survey that was sent out through REDCap, which is something that we can do and keep patient confidentiality. We are still working on the results of this, and hopefully will be presented at the AAS meeting next spring. But what we have currently, we have 600 patients that we have data on. This is not just thyroid cancer patients, but I would say about over 50 or 60% of them are thyroid cancer patients in this. There are also endocrine surgeons also do parathyroid surgery as well as adrenal surgery. So those are also included in this group. But we felt that it was important for us to see how these patients did with delay in treatment. Was there progression of disease? Was it okay to delay that? So more to come on that. So far, we have not, there are about 7% of patients who experienced disease progression during the delay, and about another 6% that had, per the surgeon's comments, had a change from the initial operative plan. So whether that was to do a total thyroidectomy instead of just a lobectomy, or whether they had to do a lymph node dissection, et cetera. So more to come from that. And that concludes my slides. And unless there are questions now, again, just a reminder to put them in the Q&A, and we can either answer them as we go along if they're pertinent to a specific talk, or we can wait until the end.
Good morning, everyone. Thank you for joining us this morning. My name is Tony Beninato. As mentioned, I'm an endocrine surgeon at the Rutgers Cancer Institute of New Jersey. So I'm going to follow up a little bit on what Dr. Lubitz discussed and give some more detailed data on how the COVID-19 pandemic affected endocrine surgeons specifically, and kind of how our practice changed dealing with during the pandemic. I thought I'd start with a little bit of a personal story of my personal COVID story. I was previously at New York Presbyterian Hospital at a site in Brooklyn up until March 15th, 2020. And then for mostly personal reasons, to be a little closer to home, moved over to the Rutgers Cancer Institute effective April 1st. So I was planning this nice little job transition when the world turned upside down and COVID hit. So left Brooklyn, was getting ready to start a new job, and then all of a sudden everything shut down, and there wasn't really a lot of clinical work to be done since due to the elective surgery shutdown. So around the same time, daycare shut down, everything else shut down. So I spent a lot of time with that little guy right down there, who's now 2.5. But that's kind of how I spent the beginning part of the COVID shutdown. At Rutgers specifically, elective surgeries were suspended effective March 16th, 2020. And then we're able to resume on May 26th. And again, as Dr. Lubitz mentioned, the question of what was an elective surgery was really a gray area. A lot of thyroid procedures were considered to be safe to postpone, but at the same time, thyroid procedures and other endocrine surgical procedures were thought to be kind of low resource procedures, meaning that we weren't doing a surgery that required a lot of staffing. It wasn't going to require a lot of inpatient admission afterward. It wasn't going to take up an ICU bed. So while some patients, we felt could be low risk for delaying their surgery, we also tried to get as many done as possible because we weren't using a lot of the hospital resources. So we took a look after the shutdown ended at kind of how our case mix changed from the previous year, so 2019 compared to 2020. And this data is submitted for presentation at an upcoming conference, but has not been presented or published anywhere yet. But we found that our 2020 cohort of patients were more likely to have private insurance compared to Medicare, compared to the 2019 cohort, which to us meant that there were fewer older patients, so patients over 65 who qualify for Medicare, that were seeking care for their thyroid disease, which made sense to us because I think a lot of the older patients who are at higher risk for serious complications if they did get COVID were more likely to stay at home. Our patients were also, we saw an increased proportion of patients who had either indeterminate thyroid nodules, so nodules where we couldn't tell if they were cancer or not, so needed a procedure to better distinguish that, or thyroid cancer patients compared to benign disease, which also made sense. So patients with large thyroid nodules or goiters who would otherwise come for surgery, again, were staying home. We saw slightly more advanced cancers during this time, and then a little bit higher proportion of patients who were having a procedure for a recurrence of a cancer. So again, all this makes sense to us. Patients who needed more urgent surgery were the ones who continued to come to our office in 2020. And some of the less urgent procedures that we were seeing in 2019 kind of stayed home, as well as the older patients, but that's understandable. This data is published, and this was a study I did with our two co-panelists, Dr. Lubitz and Dr. Graves, where this was kind of an offshoot of the Lemonade study that Dr. Lubitz was discussing. But while we were collecting patient data, we also sent a survey out to the endocrine surgeons themselves to try to see, throughout the country, how different locations and how different surgeons and different practice types were impacted by COVID and by the shutdown. Me being in close proximity to New York City, obviously we dealt with a very severe first wave. Everything was shut down, but we weren't sure if people in other parts of the country that didn't experience a shutdown, perhaps they just kept going business as usual. So we kind of wanted to get a better picture of what was going on in the United States. So we sent a survey out to the members of the AAES, the American Association of Endocrine Surgeons. Most of our respondents worked at academic institutions. We asked about case cancellations or postponement, performance of other duties outside of endocrine surgery during the elective surgeries shutdown, and information on resident education and research and kind of how that changed while the elective surgeries were shut down. Everyone who responded said that they had elective procedures canceled. And most said they were able to proceed with the procedure if it was considered to be urgent. And again, this was often left up to the discretion of the surgeon themselves or a panel at the individual institution, et cetera. About a third of surgeons took on other clinical responsibilities during this time. So when we were unable to perform thyroid procedures and other endocrine surgical procedures, about a third of the endocrine surgeons either, took care of COVID patients themselves, or a lot of people took on other people's responsibilities. So a lot of us are general surgery trained. So at my hospital, people were asked to take trauma and general surgery calls so that our trauma colleagues who are experienced in critical care could actually work in the ICU and take care of COVID patients. So a lot of people were shuffling around responsibilities and basically kind of all hands on deck doing what they could to try to help out with operations at the hospital. And on average, when elective operations resumed, surgeons had about 30 to 50 cases backlogged to schedule. And again, with the Lemonade study, we'll kind of find out a little more what happened to those patients. Surgeons also reported fewer office visits for multiple reasons. The referrals went down, obviously. Most of our referrals come from endocrinologists, and a lot of their office closed or they were seeing decreased patients. So obviously, if our referrals went down, the amount of patients we were seeing also went down. Some patients were experiencing delays in workup, fewer ultrasounds, people less willing to go out there and get their thyroid checked. And some patients even had a preference to delay care. So even when, we had the opportunity to proceed with some of these procedures, you would have some patients who were like, no, I'm okay. I want to wait until things calm down a little bit. So that kind of slowed things down for us once we got through that initial backlog of people who were waiting. The other thing we asked about was kind of how endocrine surgeons adjusted their practice to during the pandemic, during the peak parts of the pandemic. And obviously there was an increased use of telemedicine platforms. Most surgeons had said that they had really never used these platforms before the initial shutdown. And then after, a majority were using these for all types of visits, whether it be initial consults, follow-up, or post-op visits. We also asked about discharge patterns after surgery. So patients with total thyroidectomies, some of them will stay overnight, some of them will go home the same day. And we found an increase in use of same-day discharge for patients who had their whole thyroid removed. And then if we send patients home on the same day, we often observe them for several hours before we let them go home. But we saw that some surgeons were decreasing the time that they observe their patients, to try to get them out of the hospital. And I think all of this was to, maximize patient safety, less time in the hospital, less chance of being exposed to other people. And then, also it saves resources, the less resources we're using, the more resources that were available to care for all the COVID patients that were in the hospital also. So some of these adjustments to our practice were made. So from this study, we found that overall, the volume of procedures was down from before the start of the pandemic. The office referral volume was down. Both patients and providers experienced delays in care, and the reasons for those were multifactorial. And surgeons made efforts to maximize patient safety by limiting in-person exposure with the telemedicine visits, the earlier discharges, et cetera. And what people were reporting via our survey and what we experienced at our own institution seemed to be what was happening nationally. This is also unpublished data, but we looked at one of our national databases to take a look at volumes of thyroid procedures nationally, kind of in the time period leading up to the COVID pandemic, and then just after, to see how they rebounded. So you can see the red line here is benign thyroid procedures, and the blue line is thyroid cancer cases. You can see a bulk of the thyroid procedures nationally are actually for benign conditions. those in particular, you can see that huge dip right there at Q2 2020, and that was right when the shutdown happened. And then you see a recovery, but again, you don't see it recover to pre-pandemic levels. So there was about a 35% decrease in cases. And again, that returned to about 80% of pre-pandemic volume, but has not fully recovered yet. And I think that's something I'm seeing in my own practice. And I know in talking with a lot of my colleagues around the country, I don't think anybody's really up to full volumes yet. So I think interestingly, we'll have to see, it's not only those patients who experienced a delay during the elective surgery shutdown, but we'll have to see what happens to these patients that should be coming down the line, the ones who've been staying home this whole time and kind of delaying their care. The blue line there is thyroid cancer patients. You could see they did experience a dip in procedure volume also, but it wasn't as steep as for benign disease, which is understandable. So it's good to see at least that was not as impacted as severely, but you could see that blue line there really does not come up all the way to where it was before the shutdown. So again, we'll have to see whether, how these patients will present in the coming, year or years. So what does the future hold for us endocrine surgeons? Again, our volumes have been gradually increasing. I know at Rutgers, we're still not back up to full volume, but we're getting close finally, which is good because I think now patients are finally starting to feel comfortable, feel safer, and starting to seek out that care that they were perhaps putting off over the last 18 months. As I mentioned, there's a concern that future patients will have more advanced disease because of that 18-month delay in care. So we'll see those results, in the future. So will we have more locally advanced cancers, more patients with lymph node or distant metastases? I hope not, but we will see. That's all I have. So I want to thank you guys for coming and for your attention. If anyone's local to the area and looking for an endocrine surgeon, I just put my information up there for you. Thank you. And I'll be happy to take questions as well.
I'll share my screen here for my portion. Okay, so I'm going to switch gears a little bit from talking about hospital and provider level changes and talk a little bit about a survey that we put out during early COVID actually on the ThyCa website, looking at the COVID-19 pandemic and quality of life, specifically in thyroid cancer patients and survivors. And just to introduce myself, I'm Claire Graves. I'm an endocrine surgeon in Sacramento, California at UC Davis Medical Center. So as we've been discussing, and everyone knows, there were sudden changes in early spring of 2020 with a significant cut down on non-COVID related clinical activity. And it varied across the country. So as Dr. Beninato and Dr. Lubitz were talking about, there were urgent needs specifically for Dr. Beninato in New York City, where just the onslaught of COVID cases were really making it absolutely necessary to shut down. Out in California, and I also was divided between two institutions. I was finishing up my fellowship at University of California, San Francisco in the early part of the pandemic, and then switched over to UC Davis in the fall of 2020. But luckily in California, it was more of a preventative measure. So we had shut down in all our elective cases in order to prepare for a surge and divert staff and preparation. But then it luckily never really happened in San Francisco. And so there was sort of a lull of quiet, luckily for a bit. And then we sort of gradually ramped back up as we were, more certain that it might not be the same out in California that it was in New York. But we did, as part of that transition from in-person clinic to primarily telehealth visits as well. And there was just this sense of uncertainty as to, was the surge coming? Was it going to happen? When was it going to happen? How long was this going to last? And how are we going to adapt to this? And so the survey that we put out was trying to characterize quality of life and anxiety, specifically in thyroid cancer patients and survivors. We also wanted to identify and rank specific stressors. What were people most worried about? And also investigate preferences regarding healthcare interactions with their providers. Anecdotally, we were seeing, as Dr. Beninato was saying, some patients who really wanted to continue to come in and see a physician and were very concerned. And some patients have said, I really want to stay away from the hospital. How long can I put this off? I want to stay as far away as I can. So to really characterize, more on a large scale, how people were feeling. So we asked questions about patients, age and gender, also type of cancer and treatment history, and how COVID was affecting them on their daily life and their healthcare interactions. And then also ask regarding preferences regarding their healthcare interactions. And then we also ask a standard health-related quality of life survey to everyone. And so I just first wanted to start out by saying thank you to everyone who completed the survey. I'm guessing some of you on this conference may have also answered our questionnaire, so thank you so much. And we collected data from May to October of 2020, and there were a total of 411 participants who completed the survey. So just thank you very much for doing that. And just to start out, we ask, is your life different? And I think unsurprisingly, the vast majority agreed that their life was different. So 83%, so they thought their life was very different during COVID compared to before. And that included 92% who reported a change in access to extended family and social supports. 73% were under shelter-in-place orders at the time that they were answering the survey. And over half actually had a change in family income or employment that had occurred because of COVID. And looking at what exactly people were most worried about, so we asked people to rank their scale of worry about different things on a scale of 0 to 100. And thyroid cancer fell at about a 30. And that may have been because a lot of our participants who answered or post thyroid cancer treatment, they were in sort of an active surveillance mode, but had completed most of their therapy and were considered, just under surveillance currently. So people were most worried about COVID. So contracting COVID, but actually more worried about loved ones or family members contracting COVID, and also the effects of COVID on the economy. What was this going to do to the economy as a whole? And then asking specifically about healthcare changes. So the majority agreed that the way they interacted with their doctors was different. That was 80% of respondents. And then how do people feel about that? So over half actually preferred to stay away from healthcare facilities if they could during the pandemic. And people were a little bit mixed on virtual visits. About 42% preferred virtual visits than to coming in to seeing their doctor. And then about 23% were neutral. It was a bit of a mixed opinion. Less than half, unfortunately, about 43% were satisfied with the amount of information that they were getting from their doctors regarding COVID changes. And only 19% had specifically discussed with their provider about how the pandemic might affect their cancer treatment. And how does this compare to before COVID? So we actually had a unique opportunity because in 2017, there was a survey also hosted on the ThyCa website that answered a standardized questionnaire called the PROMISE Adult Self-Reported Health Quality of Life Survey that asked about a variety of questions: anxiety, depression, fatigue, pain, sleep, and ability to participate in social activities. And this is a standard questionnaire that's been used across healthy populations, cancer populations specifically, and other different chronic diseases primarily. And so we use the exact same survey that was used in 2017. Those questions were asked again during COVID. And so we were able to compare the pre-COVID to the post-COVID answers. So unsurprisingly, patients had higher scores for anxiety. And this was specifically associated with a younger age and change in treatment plan during COVID led to was associated with higher anxiety scores. And unsurprisingly, lower scores for social participation. People were not able to engage in the same sort of social activities that they had been previously. Interestingly, patients also reported lower scores for fatigue and sleep disturbance compared to before. So during COVID, I think as makes sense and we would expect, there were higher anxiety and decreased participation, but interestingly, less fatigue and less sleep disturbance as well. I thought another interesting point from the survey was that participants were more worried about the effects of COVID on loved ones or the economy, even than of contracting COVID themselves. And that there were significant changes and interactions with their healthcare providers and the communication gap that came from that different form of interaction and maybe weren't being communicated as effectively. Things about specifically their thyroid cancer and how COVID might affect them was not being actively and effectively communicated with patients. So these are all things that we can take away in order to change for the better in the future. So I just wanted to say thank you again to everyone who completed the survey. This is currently unpublished data, but we're working on getting it published soon. And again, if anyone is in the California area, I left my contact information up there as well.
So Clara, that one specific question for you is, were older or younger patients more reluctant to go into in-person appointments? Was that something you captured during your survey?
We didn't. That is something that we could look at. We did not stratify that specific answer by age, but that's a great question. I think that's something we could look at. Yeah.
So I'm reading now, another question is there any push legislatively to allow better access to telehealth? So specifically, we traveled from Colorado to MD Anderson for care for an anaplastic thyroid patient. We are unable to access telehealth with our Texas physician. Oh yes, I see where this is going. Here in Colorado, as our physician is not licensed. And I'll start by answering this. I wish there would be some legislation, and maybe that's a good idea for the AAES and perhaps ATA and ThyCa to come together to submit a proposal so the same thing happens, especially in the upper Northeast, where there are so many states that are close by. I mean, I see patients all the time from New Hampshire, Vermont, Maine, New York, Rhode Island, Connecticut, and at the beginning of the pandemic, there was sort of an emergency licensing going on for all the surrounding states, and that lasted a full year, I think, almost in most states. And so that this problem that you're discussing was avoided, but now we're in a push, and I can tell you a lot of the physicians, at least throughout the Harvard system, are really. And it takes a long time to get a license in another state. So there's a huge process, fingerprinting in some cases. And sometimes you have to go to this state in order to get your license. You have to go there to be fingerprinted or other things. And so it's a huge problem for a lot of people, and especially for patients. It seems silly to me that having a phone call and documenting it is not currently across state lines. So I think that's an excellent question and a really great idea for advocacy. The next question was, do you think telehealth appointments are here to stay? I was going to pose that to both you and Tony, whether or not you're continuing to do telehealth.
I can go ahead, Claire.
Okay. I was going to say we're largely giving patients the option. I do think to some degree it's here to stay, but I hope that it would be in a way that only increases options as opposed to limits people. So we're giving patients the option for a virtual visit post-op appointment. So particularly where we are in Sacramento, I see a lot of patients from Northern California, they're driving, 3 or 4 hours away to get there. If I just need to peek at their incision and make sure it looks good and otherwise check in with them verbally, then I think it makes sense to see them virtually. And patients have really been liking that option in general. I always leave it open if they want to come back and see in person. That's also an option too. So it only increases options, hopefully, and convenience for patients as opposed to limits. But I do think, maybe one silver lining of this is that we realize that it's okay to do that. That that it is not taking anything away. I do always want to see patients in person before I operate on them. So at some point, I'm happy to have an initial virtual visit too, but I do want to see them in person at some point before I'm meeting them on the day of surgery. So,
Tony, do you want to respond to that?
Yeah, I agree with what Claire said. First of all, I want to emphasize and empathize with the person who asked the question about the travel. It's being licensed in it. State licenses are frustrating for physicians because we have to relicense anytime we change states. So that's frustrating for us. And this raised a huge issue. Every time I did a telehealth visit, I had to verify that the patient was in New Jersey. Otherwise, it's not a legal visit. So that's unfortunate and something I think can even be bumped up higher to, the American College of Surgeons and the American Medical Association. This is something that needs to change. Patients very often travel for care and shouldn't be restricted by these silly laws. But from a personal standpoint, I'm kind of a dinosaur. I don't really enjoy telehealth appointments. I do think they are here to stay. I agree with Dr. Graves. I do insist on seeing patients in person at least once before I operate on them. But so, I try to have my patients come in, but I am flexible with them. If you have someone who's working or has small kids and they, call and they're like, is there any way we can do this virtual? I just can't make it. Then of course, I do accommodate them. But I get so much more out of a visit when I see the patient in person. So and luckily in New Jersey, we're in a situation where we have a high density of population and endocrine surgeons. So people usually don't have to travel that far as perhaps at MGH or UC Davis to come see me. So it's usually not a huge burden on the patients. But again, I do think it's here to stay. And I think it's a great option for people who need to use it.
Yeah, so I'll answer this now. There have been patients that drive down just over the border and call from their phone in order to have visits, which just seems silly to me. But yes, and it's something we don't have control over. Of course, we want to speak to our patients, and we, in an emergency situation, I can guarantee you can call your doctor and talk to them. They're not going to. It's not if there's something urgent happening, feel free to reach out to your physician, your surgeon. I think telehealth provides, like both of the other surgeons stated, some flexibility for people who couldn't otherwise travel. So there is that aspect. I do think there is something lost for not being able to interact with someone in person, but also I think all three of us do ultrasound on all of our patients ourselves, and that's something you clearly can't do through a video. And so there are certain things that you don't pick up on. And so I agree, seeing a patient in person preoperatively is important to both the physician and as well as the patients having comfort, because they generally don't get to meet their surgeon and know them well beforehand, and it's someone who's going to be taking them to the operating room. So it's definitely someone they want to be able to trust, and I think being in person can help navigate that trust between the patient and surgeon.
I will say one perk of video visits that I found, and this happens when I'm seeing patients post-op, so I'll see them in person and then they'll come in for their surgery and I'll see them post-op, and that will have sometimes been the first time that we've seen each other's faces, because otherwise we're wearing masks, and so there's always this like, oh, okay. There's always a funny moment over the video where we're like first seeing the full face for the first time. Just an odd social situation.
Well, for a while, I wasn't able to see patients in clinic. The clinic shut down. So there were at the beginning of the pandemic, there were times when I only met the patient in a mask, right? Like the first time and so I'd have to say, I'm your surgeon when we walked into the pre-op holding area, which it was different. There's one more question that says, have you had more consultations for second opinions because of telehealth? Good question. I haven't noticed that in my practice. It's a really interesting question. I don't think I've noticed that, but I can see how it would be a lot easier to just sit and talk to 3 different surgeons in your living room at the same time on the same day. But I don't know if either of you have experienced that.
I have not. I would not be surprised. Someone who used to practice in New York City, I would not be surprised if that was happening in New York City a lot. I personally have, I either have been unaware of it or I haven't noticed it much.
I agree. It hasn't been something that I've noticed either, but I could certainly, I think it makes sense to.
Maybe if the participants, they can also answer in the Q&A how they feel about it, how they feel about telehealth. That would be welcome for us to do, so we could learn from you as well. I have a question for you too, if we don't have another question right now. Do you feel like your practice has changed in terms of sending patients home following surgery? Or the extent of surgery in your own practices?
Well, let's see, we've got a couple of people, at least one person saying they'd rather see the doctor in person.
Yeah.
My kind of person. No, just kidding.
And then another person says, I have a fear of going back to the office and have been working remotely. Yes. So can you give some feedback on how safe it is to go back to the office? I think that's the question. Go ahead, Tony.
So in regards to the person's question, the only thing I can really speak from is personal experience as someone who's been going to work every day at a hospital since, April, May 2020. I feel very safe at work, but we are also in a setting where there's, at our hospital, almost everyone's vaccinated. People have no problem wearing masks. I know these are all very controversial topics, but particularly in New Jersey, in a hospital, people are very good at following public health recommendations for COVID. So I've personally have felt very safe at work. And I think that's going to vary based on where you are, your personal health risks, the percentage of people around you who are vaccinated, adherence to mask wearing, et cetera, et cetera. So I mean, your own safety at the office will depend on a lot of those things. People in the office are allowed to take their masks off at the desk. I don't know if there's any transparency at your workplace about vaccination rates. But I would feel comfortable taking my mask off at my desk around other vaccinated people. And that's my own personal feelings.
Yeah, actually at Mass General, you have to be vaccinated to work there as of this past month. So unless there are exceptions for various reasons, but it's a very, very high vaccination rate. Like and I appreciate your comments. And the overwhelming resounding sentiment is that people want to be seen in person, which I think we all agree with that. But again, there's some difficulties with anxiety over getting COVID, and so I think that. We will tell in the next 6 to 12 months, hopefully we'll be over this and be able to answer some of these questions and prepare. Hopefully not, but if this ever happened again, we'll have more information to guide how we do this. So yes, there were some places so someone said at Stanford, they were able to see the surgeon in person. So one thing to remember is that the waves in each state were at different points in time. So, New York obviously got hit initially the hardest, and that shifted very quickly to the Boston area and up north. But across the United States, those peaks happened at different times. So the three of us on the call, I think it was that peak was around the same time, or when California preventatively shut down was around the same time in the spring of 2020. But a lot of other states had different laws and different peaks and when patients could be seen. So and quite honestly, it was left up to each institution, each university, on how they were actually going to do things and to regulate it. So there was a lot of stuff going on. There were a lot of meetings, a lot of Zoom meetings about what to do and how to handle it. But I was only other thing about visits is that there and surgeries is that and for any COVID patients and everyone that no one was allowed to have visitors with them. That even included there were the exceptions for pediatric patients who were very young, but that's very difficult for someone to undergo surgery and not have someone at their bedside when they wake up that they know and love. And so I really our hearts went out to people, especially patients who were very, very sick with COVID that couldn't have their loved ones next to them.
Yeah, we in New Jersey only recently, well, probably once the vaccine came out, we allowed one support person for an initial visit. But those first few months were very hard because I saw a lot of patients by themselves. So sometimes it's very difficult to get a cancer diagnosis, and then you're hearing about treatments and surgery and all these things, and you're overwhelmed. So I think that that was very difficult. And I'm glad that now we're permitting support people in the office, but still, at my hospital, we're still not having family members in the recovery room yet. And I know that can be very difficult for patients. But I try to go find the family member, talk to them separately, do everything we can to make it inclusive. And yes, some docs allowed me to FaceTime my husband during the visit. Yeah, I had a lot of people on speakerphone and things like that to try to make the visit as inclusive as possible. And we were happy to do that.
I was gonna just agree with that 100%. I think that's great. And I always tell people, is there anyone else that you want to include? I always think that the more ears that are listening and hearing potentially different things and have different questions and different things come up is always helpful. And so, yeah, we also did a lot of, speaker phoning or FaceTiming in when we were not able to have, a whole crew in the room.
So on the flip side, I think that the virtual visits, sometimes people would feel more comfortable because they were at home and their kids and their wife or husband or dog was around. It was, in some ways, was more personal. Or a cat would, move across the screen, that kind of thing. I'm sure that happened to you guys. So there were some aspects of it that were more social and more personal in some way, shape, or form. So yeah, not the same on speakerphone. Yeah, we agree.
Yeah, back to the question you had posed before, Carrie, about changing practice. I don't think I changed my practice much during the pandemic, mostly just because I was already a big proponent of same-day discharge if it was safe for patients. And again, I live in an area that's very densely populated. So I've always felt comfortable sending my patients home. They were always very close to a hospital. God forbid they needed to come back. We have a good answering system and things at my hospital. So the one change I made was I used to be a very strict 6-hour observer, and now I've become a 4-hour observer. And my personal experience is that there's been no difference. So I'm now a 4-hour recovery room observer.
Yeah, just for the patients on the call, there's pretty good data out there that it is just as safe to send someone home. I don't want it to make it sound like it isn't safe. We've published, or I believe it was her first paper was by Herb Chen. I can't remember exactly, but showing that outpatient meaning that you have your surgery and you stay in the recovery room for 4 to 6 hours and then are sent home. We think it's much more comfortable for our patients to be at home, especially when there's a pandemic going on. I can tell you I changed a little bit. I was more conservative, especially I also, as most of us do, we do adrenal surgery and other surgeries. But I definitely, because we could get patients in if we sent a lot, that was one of the caveats. If you're not going to admit your patient, we can get your patient on the, on the operating room. So if they weren't going to take an inpatient bed, then we were allowed to see more of our patients in the operating room. So that was actually one of those things that was beneficial about thyroid surgery. How about you, Claire?
Well, I started my practice during COVID, so I don't know that there was much change.
I mean, both of you, I can't imagine I remember talking to Tony during her transition, but it's crazy. So it's been a hard year for everyone. Yeah. So we're winding down this session. I hope that everyone learned a little bit. I learned from both of you, and I really appreciate the participants. I think I'm motivated now to get that law changed about cross state. Someone has to be bringing up that legislation, but anyway, that it's making me angry now that I keep hearing it now that you guys notice that as well. So I think that's something we can look into.
I agree.
Yeah, thank you. I want to thank all the attendees for their participation and their questions and everything. So thank you very much.
Yeah, thanks for making this more interactive.
Little insight into our experience with what was going on. I know we all have our own experiences.
Yeah, we appreciate this organization, and thank you for those nice introductions, Roberta. And I think probably Gary's on the call somewhere. Thank you for inviting us, and we hope to stay involved. ThyCa is a very powerful survivor foundation, and I think they're really fantastic, and it's an honor to speak to all of you. You're why we do what we do.
Well, we really, really appreciate you being here. It's one of the most comforting things that I get to do every year is come and hear about what's happening in the world of thyroid cancer treatments and everything else. And it really makes me feel very comfortable about, going through my disease and where things are going to happen later in life for me. So I thank you very much. This will end up our session. I do believe that things have been recorded so that if people have missed things or they want to go back and look at things, then that would be they'll be available at some point. So thank you very much.
Thanks, everyone.
Thanks, everyone.
I'll see you later
Thanks
for the
so
question and answer session. Bye.